The pristine waiting rooms of high-end dermatology and cosmetic surgery clinics serve as the unexpected frontline for a severe, highly specific psychiatric disorder. This data maps the epidemiological disparity of body dysmorphic disorder. In the general U.S. adult population, prevalence sits between 1.7 and 2.4. Medical professionals in these settings face a logical trap, assuming that a physical alteration will resolve a patient's extreme subjective dissatisfaction. Clinically, BDD is a relentless, obsessive preoccupation with perceived physical defects that are either unobservable to others or appear only slight. It is a specific psychiatric condition characterized by significant impairment in daily life. The most common focal points for this obsession include the skin, hair, the nose, and general body shape, and particularly in men, muscle dysmorphia. For patients presenting with BDD, elective cosmetic procedures are strictly clinically contraindicated. Cosmetic interventions rarely satisfy the BDD patient. Postoperatively, the interventions routinely exacerbate the underlying psychopathology. To understand why surgical intervention fails, we must examine the specific cognitive mechanics driving the disorder. Treating BDD with cosmetic surgery attempts to cure a localized neurological symptom using a physical tool. This mechanical mismatch results in a measurable worsening of the underlying condition. In initial diagnostics, BDD is frequently miscategorized alongside eating disorders. A precise clinical distinction is necessary for effective treatment. Eating disorders center on weight and caloric intake. BDD targets highly specific, localized perceived defects. This diagram illustrates the diagnostic criteria loop for BDD. The cycle initiates with a trigger, the patient's perception of a slight or unobservable defect. This perception generates an immediate, disproportionate cognitive reaction, driving the patient into a state of severe distress and constant mental preoccupation. To manage this anxiety, the patient engages in repetitive compensatory behaviors, such as obsessive grooming, constant reassurance seeking, or compulsive skin picking. These actions provide a brief, temporary spike in release. That relief reinforces the cycle, immediately driving the brain back to the original obsession and locking the patient into a self-reinforcing loop between distress and action. The mechanics reveal that BDD is an obsession-compulsion loop. It operates independently of the actual objective state of the physical feature. We now revisit the logic of the cosmetic surgeon. The surgical intent is to resolve the distress through the precise alteration of the physical defect. Mapping this intervention onto the BDD pathology loop, the surgical procedure successfully severs the link at node A. The surgeon expects that removing the trigger will resolve the distress. The clinical reality, however, follows a different trajectory. With the physical node removed, the psychological system fails to shut down. The loop of severe distress and compensatory actions continues firing, completely untethered from the original defect. The patient's obsessive preoccupation often transfers to a new perceived flaw elsewhere on the body, or they develop a hyperfixation on the procedure itself. In clinical terms, this is an iatrogenic outcome. The medical intervention directly caused the worsening of the patient's condition. Altering the physical feature cannot short-circuit a neurological compulsion. It merely provides the existing compulsion with a new target. Abandoning the surgical approach requires treating BDD through the same mechanical framework used for obsessive-compulsive disorder. This approach relies on two primary pillars. The foundational behavioral intervention is cognitive behavioral therapy, specifically tailored for BDD. A critical component of this therapy is ERP, or exposure and response prevention. ERP disrupts the compulsive behavior cycle, exposing the patient to the trigger while preventing repetitive compensatory actions. General talk therapy is insufficient to break a pathology of this severity. The behavioral disruption must be highly targeted. For moderate to severe cases, this therapy is supported by a pharmacological requirement utilizing selective serotonin reuptake inhibitors, or SSRIs. Effective BDD treatment requires a specific dosing distinction. Standard SSRI regimens designed for major depressive disorder are generally ineffective for this pathology. Effectively treating BDD requires typical OCD range dosing, sitting at the highest end of the therapeutic index. This high-dose therapy is required to suppress the obsessive cognitive component of the loop, allowing the behavioral therapy to take effect. When targeted ERP is deployed simultaneously alongside OCD range SSRIs, the compounded efficacy completely dismantles the disorder's reinforcement cycle. The disorder yields when the clinician utilizes specialized psychiatric tools instead of cosmetic ones. Applying these psychiatric insights to a clinical setting requires a structural change in triage practice. Proactive identification of BDD to prevent iatrogenic harm is the responsibility of the elective procedure provider. The validated screening tool for these settings is the Body Dysmorphic Disorder Questionnaire, or BDDQ. This tool must be administered routinely prior to any elective intervention or initial surgical consultation. In this clinical workflow, a standard negative screen is simple. The patient clears the checkpoint and proceeds to the cosmetic consult. Routine screening acts as a diagnostic boundary. It protects the patient's long-term mental health and shields the physician from liability. Upon a positive BDDQ screen, the clinical response is clear. The provider must contraindicate the elective procedure. The provider then executes a pivot, moving the patient off the surgical track and towards specialized psychiatric care. Geographical access to specialized BDD care can be a barrier. Clinics must establish external referral networks to ensure successful treatment outcomes. Comprehensive telehealth infrastructures, such as Coping and Healing Counseling, or CHC, address this. Using 100% telehealth, HIPAA-compliant platforms ensures patients receive immediate access to specialized care, regardless of their location. Referral to diverse teams of licensed specialists, including clinical social workers and professional counselors, ensures the patient can access ERP and coordinate with prescribing physicians. Successfully treating body dysmorphic disorder relies on a unified front, recognizing the disorder in the cosmetic chair and transitioning the patient to targeted, evidence-based mental health care.